Assalamu alaikum. This is Dr. Naveed, consultant neurologist at Hamad Medical Corporation, Qatar, and I'm very thankful to the committee for inviting me to give two sessions actually in this meeting. First session is on the bridging therapy in acute ischemic stroke. So let's just start with the session. Um, um, So as we know that a stroke is one of the leading causes of death and one of number one cause of serious long-term disability. In the US, every 3 minutes, 42 seconds, someone dies of an acute stroke. Problem with the stroke is that it leads to poor functional outcome if not managed. And most of the patients suffer from poor functional outcome is because the failure in recognizing the key symptoms and presenting late to the hospital, often beyond the therapeutic window. It is estimated that in the coming 20 years, between 2015 and 2035, the estimated direct medical stroke-related cost can be projected to double from 36 billions to 95 billions. Now, in terms of management of acute stroke, there are landmark steps which happened over the period of last 25 years. The first landmark step was introduction of intravenous thrombolysis by the famous NINS trial in 1996. Following that, PROACT trial showed that intra-arterial use of pro-urokinase for MC occlusions within 6 hours of stroke onset. Later, the IMS trial, International Management of Stroke, tried to use a combination of intravenous and intra-arterial thrombolysis in acute ischemic stroke. But because of the safety issues, that was not accepted. Later in 2008, ICAS-3 trial showed extension of thrombolytic time from 3 hours to up to 4.5 hours in a significant number of patients. Following that, the efforts to improve the stroke outcome in patients with, especially with large vessel thrombosis, continued in 2000 until 2013. The endovascular thrombectomy trials continued to fail to demonstrate improved patient outcome following endovascular thrombectomy. But these trials did let us understand the problems in designing the study, and that helped with coming with more stringent selection criteria to select patients in randomized controlled trials. Following these, in 2008, 2014, and early 2015, we have 5 to 6 published randomized controlled trials which revolutionized the treatment of large vessel occlusions to the vascular thrombectomy. So these trials range patient selection between 6 hours up to 12 hours, and it showed that there is a significant improved outcome at 90 days in patients who undergo thrombectomy as compared to medical management. And you can see all these patients have significantly improved relative risk as compared to medical management. But post endovascular trial, there is a report of Hermes collaboration, which tried to pool all the data of thrombectomy patients from those positive 5 trials in different scenarios done across the various included population. The Hermes population, the Hermes trial, the Hermes collaboration showed actually that in all these patients which went through thrombectomy trials, a total of around 1,300 patients with a median age of 68. Most of them were M1 occlusions and internal carotid occlusions, and at least 8% of them were M2 occlusions. The median symptom onset to reperfusion was 285 minutes. The Hermes collaboration concluded that that endovascular thrombectomy significantly reduces disability at 90 days as compared to control patients. The number needed to treat in order to reduce disability of at least 1 point on modified Rankin score is 2.6, which is significant for any interventional study in any type of management of medical conditions. And mortality at 90 days and risk of intracranial bleed did not differ between the two groups. But what about other patients, patients who are not eligible for endovascular thrombectomy according to the criteria of these studies? These patients are patients who present with late presenting stroke symptoms, or patients with unwitnessed stroke, and stroke symptoms in patients who wake up with stroke. So in order to encompass these patients, the two trials were done. The first is drawn trial, which included 206 patients with 99 patients in control group and 107 patients in endovascular therapy group. At 31 months, the enrollment was stopped because of the pre-specified interim analysis, which showed a significant improved functional independence at 90 days in about 49% of patients in the treatment group as compared to 13% in the control group. The rate of symptomatic hemorrhage did not differ between the two groups, which was not statistically significant, nor the 90-day mortality was different. Hence, the DAWN trial clearly showed that in a selected group of patients who undergo thrombectomy between 6 to 24 hours, there is a significant 48% versus 13% improved outcome with 73% relative risk reduction, and number needed to treat was only 2.7. If we dichotomize patients between 6 to 12 hours and the patients between 12 to 24 hours, both these groups showed significant improvement in the interventional group as compared to control group. The second trial was a diffuse 3 trial in which 182 patients underwent randomization, 92 in the interventional group and 90 in the medical therapy group. The endovascular thrombectomy plus medical therapy group as compared to the medical therapy alone, so that is the interventional group, was associated with favorable shift in the distribution of functional outcome, that is MRS, at 90 days, showed significant improvement in the intervention group as compared to the control medical therapy group, and a higher percentage of functional independence, which is 45% versus 17%, and which was statistically significant. The 90-day mortality was less in the interventional group as compared to the medical therapy group, and there was no significant difference in the symptomatic hemorrhage or in the serious adverse events in this trial. So this trial, as you can see, showed in the outcome 90 days, 44% versus 16% in the medical therapy group. So it showed significantly improved outcome in patients who underwent endovascular treatment predefined by a specific imaging criteria. Hence, there is a clear evidence of overwhelming benefit of mechanical thrombectomy in patients with large vessel occlusion who present as acute stroke. So the question is whether there is an additional benefit to give IVTPA treatment prior to thrombectomy, which is called the bridging therapy, over thrombectomy alone is still unproven in randomized trials. Whether there is an additional benefit of thrombolizing such patients if it is a large vessel occlusion, and this is what we are going to look into that. Before looking into this thing, I will talk to you about a case which we have recently encountered at our center, just to show the effect of thrombolysis in large vessel occlusions. This is a 35 years old South South Asian lady with no chronic medical illnesses. She presented with sudden onset right-sided weakness, dizziness followed by syncopal event. A friend noted left-sided weakness at 1800 hours. She reached emergency at in a 1 hour 50 minutes around, and her CT scan was done at 200 hours, which is exactly 120 minutes from onset. Her examination revealed a blood pressure of 148/72 millimeter of mercury, a GCS of 15/15. She could tell her name but was not able to answer all questions correctly. She had a left facial upper motor neuron weakness, left hemiparesis, decreased sensations, dysarthria, tension. The NIH was the score was 8. Her plain CT was, as you can see, it shows possibly a right, slightly hyperdense MCA sign, but other than that, there are some changes in the cortical area of gray-white differentiation in this slide as well, and there is some swelling of the insular ribbon. The patient was started on IV thrombolysis by a neurology fellow in the CT room. Then this is the CT perfusion which was done. As you can see, there is a significant evidence of reduced cerebral blood flow and a small area of MASH defect in the MCA territory, but there is a significant element of mismatch in the complete MCA territory. But after looking at the CT angiogram, as you can see, there is a clear evidence of presence of a thrombus in the right ham 1 MCA. But the on-call neurologist who was on call, his opinion was that a CT scan plane shows hypodensity in the insula and the basal ganglia. There's a gloss of gray-white differentiation and gyral swelling in the anterior deviated MCA, and this is reflected by reduced cerebral blood flow as well as a loss of significant flow in the distribution of right MCA territory. So it was decided by the stroke neurologist that the TPA should be stopped because of risk of hemorrhagic conversion. By that time, 17 milligram was given, and patient was taken for direct thrombectomy. Thrombectomy was as soon as the first injection was run through the right femoral puncture after local anesthesia. The right IC angiogram, as you can see, this is the first run, and it shows complete recanalization of the occluded right MCA by the RTPA, which is only 17 milligram was given, and there is a free flow in the right MCA branch. So 17 milligrams of TPA, right M1 occlusion, clearly recanalized. If you look back into the AHA 2019 guidelines, it is very clearly mentioned that it is a class 1A evidence that in patients eligible for IVTPA should receive IVTPA even if mechanical thrombectomy is being considered. So in this particular case, IV thrombolysis was stopped and thrombectomy was planned, but first injection revealed clearly that IV thrombolysis can open up vessels. If we look at what is the evidence of recanalization, the effects and side effects of TPA in acute large vessel occlusion. We know that number needed to treat to improve one patient, complete improvement of one patient is 6 to 8. Similar to thrombectomy, the underlying mechanism for benefit of IVTPA is reperfusion of the ischemic penumbra through the vessel recanalization. We know that within the first few hours, the number needed to treat can be as low as 4.3 in thrombolysis, and the number needed to harm can be as high as 65 to 38. However, the odds of successful recanalization of a proximal large vessel occlusion with this treatment is low and depends on several factors, and we are going to discuss those factors, which include size of the occluded vessel as well. Different studies have shown different rates of recanalization in patients with IVTPA. This is one of the major study mentioned by Mishra. This study clearly showed that there are different factors which can affect the recanalization rate in terms of in cases of thrombolysis. Recanalization rate depends on residual flow within the clot, yani the flow within of blood within the clot, because of which is called clot permeability. If clot permeability is present, there is a 5 times more likely to the for the patients to develop a recanalization after intravenous thrombolysis. Uh, then shorter clot length, less than 15 millimeter, they are more likely to reperfuse. Patients who have distal clots and the clot interface ratio in Hornswell unit of less than 2, they are more likely to reperfuse. As you can see in this trial, distal clots they were more likely to recanalize, 38.9% in M2 as compared to 1.6% in TNL occlusions and 28.6% in tandem occlusions. So the study clearly showed that clot characteristics on CT angiogram can help physician estimate a range of early reperfusion rates in patients with IV thrombolysis. And not only the recanalization is with clot characteristics helpful, but this also improves the outcome at 90 days, as you can see in patients with distal IMC occlusion. The outcome a good outcome is in 75% of patients as compared to 23% of patients in with the T occlusions. Other studies also showed that relevant recanalization before endovascular thrombectomy can be achieved in 8.8% patients, and thrombus dislocation in 7.2% patients even before thrombectomy. Recanalization rates were higher, significantly higher in this study in distal as compared to large and proximal occlusion. As you can see in this study, M2, the distal recanalization rate was higher, 17.6 as compared to 5.4% in patients with receiving IV thrombolysis before bridging therapy. So, but the use of IVTPA, it is limited because of multiple factors. First of all, the shorter window time for IV thrombolysis, because can be given maximum until 4.5 hours. There's an increased risk of symptomatic systemic hemorrhage complication and angioedema associated with IV thrombolysis. Stringent exclusion criteria like recent surgery, use of anticoagulation, frequent occlusions of the reperfused vessels, and mostly because of a poor rate of complete recanalization. Hence, there is emerging evidence that IV thrombolysis from independent randomized controlled trials in large vessel occlusion. So, in patients who with large vessel occlusion, we have seen now recently in second generation thrombectomy devices, they are highly effective in recanalizing vessel up to 24 hours. This rate can go from 70 to 84%. Also, we know that mechanical thrombectomy is associated with better functional outcome measures, and as compared to patients who do not go for mechanical thrombectomy. So this finding has led to the hypothesis that even in patients with IV thrombolysis, eligible patients, systemic thrombolysis may not provide additional benefit or may even be harmful compared to thrombectomy alone. Therefore, the indication for systemic thrombolysis in such circumstances has been questioned. But the natural history data shows that outcome in patients with large vessel occlusion are significantly worse, whether they are treated with IVTPA as compared to patients who are, if they're not treated with IVTPA as compared to patients who are treated. But because there are no randomized controlled trials which confirm that a direct mechanical thrombectomy is superior to mechanical thrombectomy plus IV thrombolysis in patients who otherwise qualify for IV thrombolysis. So because of the safety concerns, along with the concerns related to delays in the thrombectomy initiation, due to the time required to administer IVTPA, along with cost considerations, some have advocated that to avoid IVTPA patients with large vessel occlusion, which can be quickly treated by mechanical thrombectomy. So rather than wasting time in giving IVTPA and delaying the mechanical thrombectomy, it is better to take them for directly for mechanical thrombectomy. That is why it is reasonable to assess the safety and efficacy of direct mechanical thrombectomy versus mechanical thrombectomy with IVTPA in context of a randomized control trial. However, but still we need to keep in mind that in the absence of contraindication of IVTPA, the available data do not support any added benefit from withholding IVTPA prior to thrombectomy in the IVTPA eligible patients. So there are two trials actually which have compared IVTPA plus mechanical thrombectomy versus direct mechanical thrombectomy. And these randomized controlled trials, the idea was to show that primary mechanical thrombectomy was non-inferior to the bridging IV thrombolysis with alteplase, immediately followed by mechanical thrombectomy in acute ischemic stroke, initially presenting to the thrombectomy capable centers. The first trial is the direct MT trial, which included 656 patients with ICA M1 or M2 occlusions who could be treated with full dose alteplase, and that is 0.9 milligram per kilogram within 4.5 hours of symptom initiation. This trial was done in 41 centers in China. And the trial clearly showed that primary mechanical thrombectomy was non-inferior to combined IV plus mechanical IV thrombolysis plus mechanical thrombectomy with regard to primary outcome, that is 90-day MRS shift, the absolute odds ratio of 1.07, which was statistically significant, despite the absence of IV thrombolysis being associated with lower rates of successful reperfusion before mechanical thrombectomy. The trial showed that primary mechanical thrombectomy is the same as intravenous plus mechanical thrombectomy, intravenous thrombolysis plus mechanical thrombectomy. The other trial was a SKIP trial. This was done in Japan. It included 204 patients with IC or M1 occlusion within 4 hours of symptom onset. This trial used reduced dose of TPA. As we know, in Japan, 0.6 milligram per kilogram is being basically used. And this trial was unable to demonstrate a non-inferiority of primary mechanical thrombectomy over combined therapy. Even though there was no significant difference in the functional independence at 90 days, the pre-specified non-inferiority margin was not reached. Both for primary and secondary outcomes. The successful reperfusion, symptomatic hemorrhage, and 90-day mortality did not differ in the two groups. However, the incidence of ICH was higher with bridging therapy. But this trial, as it did, was unable to demonstrate non-inferiority. So with the exception of these two trials, most of the data available is from retrospective studies, and majority of the comparative studies to date, patients in the direct mechanical thrombectomy were not the candidate because they were not most of the patients because they reached the centers late. That's why they were not the candidate for IV thrombolysis. So that's why this data is weak on establishing a direct comparison between the two groups. So the key arguments in bridging therapy is the multiple arguments which we are going to evaluate. Why IV thrombolysis is IV thrombolysis better as compared to going for direct mechanical thrombectomy in patients who are otherwise eligible for mechanical thrombectomy. The first argument is that IV thrombolysis, we know that it is proven to recanalize occluded intracranial vessels. I've already shown some of the studies. There is another study which is done by Zengeri. It showed 56% of patients with acute large vessel occlusion showed complete recanalization in 24 hours in treatment with the IVTPA. They also showed that they also observed a greater success with recanalization, more with distal occlusion as compared to proximal occlusion, although lower rates of recanalization with IVTPA in 24 hours was reported by the REVASCAT trial. In the INTERSECT trial, investigators, they evaluated thrombolyzed patients within 6 hours post-TPA using follow-up CT scan prior to the thrombectomy. And they compared with patients who did not receive IVTPA, the patients who were thrombolyzed, they were more than twofold greater probability of achieving complete recanalization within 6 hours of IVTPA. That is 30% versus 13%. Unsurprisingly, the independent predictors of successful recanalization in large vessel occlusion in such patients were early because the thrombolysis was initiated early. The thrombus was more distal with lower rates in proximal and higher rates of recanalization in distal M1. Uh, there are the other two trials, the SWIFT Prime and Extend IA trials, reported recanalization rate between 7 and 11%. That also occurred. They were actually more earlier. They evaluated the recanalization time between IVTP administration and the first run of the pre-thrombectomy angiography. So they showed 7 to 11% recanalization rates in patients with who are going for thrombectomy. Second argument is that IVTPA remains the only effective therapy for acute ischemic stroke when the mechanical thrombectomy is not immediately available. And we know that the acute stroke management in major centers depend on resource allocation and specialist availability. Not every center is equipped for is a comprehensive stroke center, and most of the patients who actually with large vessel occlusion, they are initially evaluated at health care facilities which lack the personnel and resources to provide emergency thrombectomy. In US, the nearest endovascular capable center is more than 1 hour away from the third of the US population, and the considerable time delay between the initial medical contact and the endovascular center can be as long as 2 hours, and we know that the more delay in door to puncture time and door to recanalization, it can lead to significant risk in permanent disability and mortality. And every 15 minutes delay carries the risk of increasing, reduces the likelihood of ambulation, increases the risk of a hemorrhage, and increases the likelihood of in-hospital mortality and discharge. Hence, in patients with large vessel occlusion, IV thrombolysis has shown to increase the odds of early recanalization and can potentially lead to better outcome in patients who are waiting for in which the thrombectomy is not readily available. Also, there has been a discussion between direct to mothership treatment approach versus traditional drip and ship model, and because there is no clear distance to time cutoff. Cutoff time is still unknown. Most of the ongoing randomized controlled trials address the benefit of direct transfer to endovascular centers in patients with suspected large vessel occlusion. Transfer to closest hospital is still because we don't know that what is the time cutoff to reduce the outcome disabilities. Presently, the transfer to closest hospital remains the standard approach for most regions, although the use of mobile stroke units have proven to be more effective means of reducing long-term disability by routing patients to the endovascular therapy center. Then the third argument is that in multifocal embolic strokes, IVTPA may recanalize remote smaller occlusions. As we know that in patients with embolic infarctions, multiple embolic infarctions, thrombectomy may not be the option for smaller, more distal vessels which are occluded concomitantly with the large proximal vessel. In observational data, 6 to 26% of patients with multifocal infarctions, they may have distal or remote occlusions. Hence, in those cases, IVTPA may facilitate reperfusion of the oligamic tissue because of inaccessible branch to endovascular therapy. Furthermore, endovascular recanalization, when we recanalize a vessel through a thrombectomy, it may result in distal or remote emboli that cannot be treated by reattempted thrombectomy. So hence, in those cases, IV thrombolysis or any additional local thrombolytic or antithrombotic therapy can help improve distal recanalization without a significant increase in the risk of hemorrhagic transformation. The fourth argument is that IVTPA, this is the most interesting argument, that IVTPA can augment the effect of thrombectomy devices during clot retrieval. Now, this concept in the earlier retrospective studies using first and second generation thrombectomy devices, the time from groin puncture to successful recanalization, which is TIMI 2 or 3, was significantly shorter in patients pre-treated with IVTPA. Another retrospective study showed that in 68 patients with proximal MC occlusion, pre-treatment with IVTPA was associated with higher rate of successful recanalization and shorter delay from groin puncture to recanalization, which is 35 versus 60 minutes. In the ASTRA trial post-hoc analysis, a significant reduction in the number of thrombectomy passes was also noted in patients who used IV thrombolysis. But meta-analysis in 2019 of 29 studies, it showed no difference in the rate of effective reperfusion, whether the patient used IV thrombolysis or not. In the direct empty trial, there is a nominal 6% higher rate of successful reperfusion in patients who underwent thrombolysis as compared to the patients who did not go thrombolysis with thrombectomy, which is 85% versus 79%, but this was not statistically significant. Then the fifth argument is the risk of systemic hemorrhage, not necessarily intracranial hemorrhage, is greater in patients who use combination therapy as compared to direct medical therapy. And the different studies have described different rates of systemic hemorrhage, along with growing hematomas associated with thrombectomy in patients who receive IV thrombolysis, and not a single. But we still remember that not a single study, cohort study to date, have published a higher risk of symptomatic ICH when IVTPA is used in conjunction with mechanical thrombectomy. The SKIP trial reported a higher rate of ICH with intravenous thrombolysis plus mechanical thrombectomy, but the SKIP trial did not show non-inferiority. Also remember that. So there are different factors which can be used. I'm getting short in time. There are different factors which can favor potential thrombectomy, which is as compared to thrombolysis, prior thrombolysis: longer clot size, low clot burden, proximal IC occlusion, tandem occlusions, longer time from stroke onset, calcific lesions, a large infarct size, low aspect score, prior use of anticoagulants and anti-thrombotic agents, very old patients, severe hyperglycemia, requirement of peri-procedural antithrombotics in patients with tandem occlusion, calcific. There are different criteria which can help in finding out which patient will probably benefit from direct thrombectomy, or patients who will benefit from mothership bridging IV thrombolysis therapy as compared to patients with going for direct. These are the different criteria which are used in order to assess for an individual patient that they will benefit from prior IV therapy, thrombolysis, or direct thrombectomy. So the conclusion of this presentation is that we cannot say with confidence that IV thrombolysis prior to mechanical thrombectomy is superior to mechanical thrombectomy alone in patients with large vessel occlusion. The direct empty trial did not show any difference in patients who underwent IV thrombolysis versus mechanical thrombectomy alone. The SKIP trial results cannot be generalizable because it did not show any non-inferiority. Plus, the use of a TPA dose was smaller. There is no attributable risk of symptomatic hemorrhage with IV TPA over mechanical thrombectomy reported in the literature. But also we need to keep in mind that there are other benefits of TPA, that it can there's a higher chance of early recanalization for patients in whom mechanical thrombectomy is not readily available. In whom mechanical thrombectomy is not feasible because of vessel tortuosity, impossible access on chronic post-tumoral occlusion, and early recanalization before thrombectomy, and faster mechanical reperfusion and lysis of distal or remote branches occlusion uh, are the benefits of IVTPA. So all these benefits, they require additional prospective trials to confirm that prior treatment with IV thrombolysis followed by thrombectomy is of more benefit than a mechanical thrombectomy alone. Thank you very much.